looking into the future trends and innovations in hospital operations. So for that, I would request all the panelists to come on stage as I announce their names. Let me join me in welcoming Dr. P.M. Uthappa, Group Chief Medical Director of Narayana Health. Welcome, sir. Dr. Mahendra Kumar, Director of Medical Services, Kauvery Hospital. Dr. Deepak Balani, Medical Director of Sagar Hospitals. Dr. Sandeep D'Souza, Chief of Medical Services, Sakra World Hospital. Welcome. Srijit Narayanan Edamana, Chief Operating Officer of Apollo Ayurved Hospitals. And Shrivalli V, CEO of Kinder Hospitals. I think she is joining in some time. Yeah. So, as mentioned, since this panel we are looking at from an hospital operations perspective, one on the healthcare delivery front, how do we make it more efficient, and what are the measures or initiatives being undertaken to optimize this efficiency, and as well as overall operations management perspective from a hospital, what are the sort of innovations that are being conceived and planned. So I will start again one round to each panelist. And I would like all of you to highlight one area. What we are trying to first gather is, unless we don't sort of identify the challenges, we can't look at the solutions. So in the current healthcare delivery system, what are the main inefficiencies that you would, so I would like each of you to highlight very briefly one inefficiency and what sort of solution or actions you feel need to be undertaken to mitigate or optimize that inefficiency. Starting with you, Dr. Uthappa.
Hello. Thank you for inviting me here. Very interesting session this morning. The one inefficiency or one challenge I would really consider and stress upon is communication. We are not good communicators. Because of poor communication, we have fragmented care. Hospitals don't communicate with the patients, the doctors don't communicate with patients, doctors don't communicate with doctors, doctors don't communicate with nurses in a proper manner. When a patient comes to the hospital, the patient can see multiple specialists, and there can be duplication, there can be errors in the medications, so on and so forth. And this really affects the patient care and the outcomes for the patient. And if you look at the patient journey within the hospital, when you have this kind of poor communication, it really leaves them in a very abysmal state. So most of the time, they do not appreciate that particular journey or the time they spend in the hospital. So again, there are many other inefficiencies. So I just picked on something very basic, something very common, which we see on a regular basis. Again, if you want to highlight on the solution, I'm from Narayana Health, so we have looked at it in great depth over the last couple of years. So one of the things we looked at is the patient journey as such. So the moment the patient accesses our care to the point they come to the hospital and leave the hospital, you look at the journey, look at the touch points and see where all they need proper communication. So now we have a patient portal called an NHCare app. So you can go through the app, and if you're a first-time visitor, you have the flexibility to choose your own appointment, the time, the date, the consultant. And if you don't know whom to get your appointment from, there's a chatbot who directs you. So there is communication, there is some predictability now for the patient. So when they come to the hospital, very likely that you might not see anybody, you might directly go to the consultant room because you have an appointment, and we kind of assure you that we will see you within 20 minutes. And when they see the patient, when they see the doctor writes everything in the EMR now. We are 95% outpatient EMR compliant. And the doctor decides on treatment plan, and the moment the patient walks out, that treatment plan and entire clinical communication is in the patient's app. So that's an opportunity for the doctor again to speak to the patient, give proper information. Now there is not much waiting. Now when they come out, they know exactly where to go because the app tells them how to pay. They can pay it in the app itself. They don't have to stand there. They get their blood test done, and the TAT, everything for the blood test, imaging, everything the patient knows in advance. This is one of the ways you can improve your communication using technology. And again, there's a lot of things in the inpatient-patient flow also.
Okay.
Thank you.
Welcome. Basically, communication between the different stakeholders, internal stakeholders in the overall healthcare ecosystem is one of the main challenge. And yes, from the technology front, a portal can be at least a starting mode of communication for better interaction. Okay. Dr. Mahendra Kumar, the same question to you. One major challenge that you would like to highlight.
Hi. In India as such, when we look at it, the availability of healthcare has been scattered. What I mean to say is the healthcare burden has lied mostly on the private sector and less on the government, because the infrastructure part as such provided by the government is highly inadequate, because of which the private health sector has been burdened with much higher and higher load of managing the health of the country. As you look at it, even the budget also allocated to health is much lower, very dismal in compared to many developed countries. Though we are on the path of a developed country, but it's still a very far journey for us to achieve that. Availability of trained manpower is another issue. How much ever technology we try to bring in, we import softwares, equipments, instruments from every other country, paying huge prices. But availability of manpower to handle them efficiently and provide a good treatment or protocol to the patient is another issue which we lack today because of a very not availability of a standardized way of education, and also their recruitments into the hospitals.
Okay.
And also the insurance has not penetrated much in the country, because of which the burden on the man for out-of-pocket expenses is actually high for us to achieve a good health for the country.
Okay. Okay. So primarily, the main issue which I take up is lack of a standardized skill set for each of the people involved. The insurance part I'll take up in the later round of discussion. Great. Thank you, sir. Dr. Deepak Balani, your views on this.
Thanks, Rajneesh. Good afternoon, folks. We have all spoken quite a bit about comparisons with other sectors, airline and financial services sector, etc., etc. One thing common with all this is that these are all services sectors, and healthcare, as we all know, is one of the most complex in that no two patients are alike, and similarly no two doctors, no two nurses, no two healthcare professionals, and therein lies one of the biggest crunches. Dr. Mahendra was highlighting the lack of skilled manpower. So each one believes medicine is an art, it's a skill, and you may not find too many people who believe it's a science. Therein lies a big factor to my mind. And attached with that is what Dr. Uthappa calls the gaps in communication. And these all boil down to the fact that all too often patient does not get the care he needs and deserves. One thing could be, okay, we have not got the time to assess him appropriately. The clinicians are too rushed. We don't have the time, effort, energy, inclination to look after him appropriately, be it the nurses, be it the technicians, be it the doctors, etc., etc. So see, one approach for this, yes, everyone will say AI will help us, etc., in coming to the right diagnosis. But in all this garbage in and garbage out, how do we get in that particular information and get out that particular information? So the whole thing really is somebody has made a diagnosis and asked for some type of assessment, some care, etc., etc. And then the next step, half the message got diluted. Dr. Yatish Govindaya in the morning spoke of continuity of care, which is a major challenge. Right from at home, should I take my dad to hospital or not? If I do, how do I do it? How do I access it? And how and at the emergency, then what's the decision making to happen? Then I go to the ICU, then I go to the wards, etc. So now in all this, it is a very complex system. You have to be inside it to understand what really it is. And there, one possible solution where IT will also play a major role, though so many other factors, is that of standardization. This is a concept introduced or popularized by this surgeon called Atul Gawande. Checklist Manifesto was a book he came out with. So it's an organized, structured, systematic kind of an approach. There are some basics. Whenever in the morning you were saying there's a code blue, you will say that you didn't know, he was all right. Now the structured approach to is rock bottom basics. Are we checking the vitals properly? Are we assessing the A, B, C's, etc., of our assessment and care appropriately? Not to go too high deep into it. The rock bottom basics remain the same. They were the same 50 years ago. Probably they will be the same. So there is a checklist kind of an approach. The rock bottom basics fundamental. There's no limit to the depth to which we can go, the complexity to, but there should not be a deviation from the basics.
Okay.
There's a thing of a checklist. And that is where the organization for proper EMR comes in. The EMR which is not only as comprehensive as required, but as robust to take care of other eventualities, and importantly, very structured such that it is very user friendly. The whole thing about adoption, a user friendly, comprehensive EMR. I remember at one point in one particular place I worked in, I found that I had 11 different logins and passwords. If I have to log in here for this, log in there for that, log in there, I'm not going to remember it, and I'm not going to do it. Simple, I'm not going to do it.
Use it.
It's an integrated, comprehensive, solid, robust, user-friendly EMR is the need for OPR and the solution to much of these things.
Okay. So what you are basically saying, summing up, is data is critical, but more important is assessing and analyzing the data very properly, and thereby building a very robust EMR for that purpose. Great. Thank you. Dr. Sandeep D'Souza, your views on this.
Good afternoon, everybody. So I think possibly in the hospital, there are too many inefficiencies. So if we have to just talk about one, which the other panelists have already not talked about, I would like to pin it on waiting times. So waiting times is a royal pain for any patient, because every patient in his right mind, in his own mind, is in a medical emergency. It may be a cough, it may be an elderly person, it may be a young person, it may be you and me. For us, that's the most important thing, and any wait time in the hospital, even sometimes, even if it is just 1 minute, is a royal pain. And how do we, so that can be easily termed as, as a big inefficiency. And we all know wait times are not in minutes in the hospital, it goes in hours. So in the outpatient, you could be waiting for hours. In the radiology department, you could be waiting for hours. For your discharge, you could be waiting for hours. For your admission, you could be waiting for hours. For your surgery, you could be waiting. Post your surgery, you could be waiting. So waiting is constantly throughout the entire hospital system. Length, breadth, and depth is a highly inefficient, probably the most inefficient and the most expensive part of the whole thing, because it calls on all resources to just hang around till the wait is all completed, and so we can do our task. So how do we really minimize this wait time to the max? So I think old-fashioned is what I would like to say. The first most important thing is to be having a good structural design of your hospital, a good structural design, a good layout, an efficient layout which allows processes to work efficiently. So that's the first part. The second thing is to build capacity. So when you are in your structure, you need to be able to build capacity for the next 20, 30, 40 years away, so that as you grow, you're not becoming more and more inefficient, and then more and more expensive, and then more and more in the red. So I think these two things is one
Okay.
solution. Of course, backed with good manpower, good processes, and of course in the age that we are, good IT services, and now integrating with AI. Of course, all these solutions there are going to be a lot of solutions. It'd be difficult to enumerate all these things, but old-fashioned is what I would like to say. Good structure, good build for the long term, and good processes with good people, and of course then you have the IT support and all those things to bring things in. So this is what I would say.
Okay, so summing it up, having proper structural design of the hospital itself, defining very good business processes, and as you mentioned rightly, looking at that implementation also very properly. Thanks. Srijit, I'll come to you next with your views on this.
Good afternoon, everybody. Thank you for giving me this opportunity to talk today. So, one of the challenges I would say is that if you look at the healthcare demand or the customer expectation is now slowly moving from an episodic type of a management of health to more of a continuum of care. And this primarily comes because if you look at even data from WHO, etc., 60-65% is the NCD burden. And if I look at my data itself, 55-60% of my patients have more than 1-2 comorbidities when they come in. So what happens is progressively I'm not trying to handle one episode, but I'm going to have a continuum of care through which I'm able to manage the condition and improve the quality of life along with the disease itself. So if you're in that kind of a paradigm, what happens is that you have to be extremely fungible in the way you're delivering the care. Sometimes you might be doing it with just medicines and kind of a health management plan going. Sometimes it's going to be in hospital, and sometimes it's going to be at home. So there are multiple ways of managing that care. And with that kind of a thing, suddenly you see that lot of chaos coming in. Like Dr. Uthappa spoke about poor communication, right? I mean, you sent a prescription, but you forget to kind of even follow up with the patient, right? And patient just goes somewhere else. So these kind of things are more and more coming, right? So what we have done, 2-3 things that we have done and which has helped us tremendously, both in terms of outcomes as well as net promoter score. One is that we have switched from a prescription to a health plan mode for every patient who comes in. We don't just talk about, you have this medicine, but we talk about, okay, let's work on a plan to actually take you to the next level, right? I mean, so let's phase it out. And there's that whole thing of, even if you look at sustainability and SDG goals, about the informed plan of care kicks in, right? And the patient signs off saying that, oh yeah, this is the plan that we're going to sign off, and the doctor also kind of signs off. Then what happens is that the outcomes, etc., once it is signed off, it's rigorously tracked so that there's no ambiguity. Patients are also happy. We know where we are heading. More information is passed on. Patients are building trust. That's the kind of approach that has tremendously helped us to kind of even bridge the communication gap that we spoke. And the outcome so far for us has been tremendous, because our NPS score is somewhere around 88%, which is something like a benchmark now for our sector. And likewise, 30-35% of our customers come through referrals, and we don't even charge them for anything of referrals, because that fundamental trust gets built in the moment you are able to kind of manage them throughout the journey.
Okay. So basically, emphasis on the continuum of care, and thereafter, with continuum of care, you have to sort of plan the thing with a rigorous mechanism and track. The tracking is the most important thing here. Okay. So at this point, I'd just like to, our other panelist has joined. May I welcome Shrivalli, VCO of Kinder Hospitals. Yes, ma'am. Can we have her on stage? So you have arrived at the right time because the next question is for you only. We are doing a round with each of the panelists. Basically, it's around optimizing healthcare delivery for more efficient patient care management and innovations in hospital operations. So, what I was asking each panelist to enumerate one big challenge in patient care and overall hospital operations management which you are facing now.
I think, first of all, thank you all, and it's a great opportunity for all of us to be here as well, with all the great dignitaries here around. One most important thing operationally that we feel challenged or we find it difficult is passing on, let's say, the ball from one department to the other. You know, I would say department silos. That is one thing that whatever technology comes, whatever may be the situation, however we would take it up, that's something that we should always be working on. That is something that I would like to say.
So each department is sort of working in silos and there is not enough synergy and integration between them. It's an extension of what earlier Dr. Uthappa had also said about lack of communication amongst different stakeholders. Great. So we have heard of various challenges from all the panelists. Now let's take up some of these issues. I'll come back to you, Dr. Uthappa. When you mention lack of communication, now overall healthcare ecosystem, all the internal stakeholders, there is the doctors, the surgeons, the clinicians, the patients, nurses, other caregivers, even the hospital administrator people. And there are important external stakeholders increasingly. One is the healthcare insurance. One is probably the pharma companies themselves. Then the pharma supply chains. So, as you mentioned rightly, that there is a lack of communication between all these internal and external stakeholders. So, how critical is the situation, and what are the ways hospitals are looking to improve that situation?
I'll tell you first, to begin with, about our medical education system. I'm a clinician. I've practiced for 25 years as a nephrologist. In India, when you're studying MBBS or any of the PG courses, nobody talks about communication. Okay? We become excellent doctors, we are excellent in doing procedures and surgeries and everything, but it does not train you to go out and work as a consultant. And I also worked in UK for a long time, 20 years, so the difference there is, in UK, everybody speaks one language. Okay, there's no question about it, no issue about it. But right from medical school all the way to when you become a consultant, and even if you're a consultant, you have to go through communication courses. Okay, and what does this communication course tell you? Speak softly, speak slowly, don't use jargon, and make sure you ask the patient to talk back to you after you speak something, so to know how much they have understood. Even if we have to create a patient leaflet for any particular condition, you just can't write it. It has to be vetted by a company, an NGO, which looks at plain English. So can the common man understand? So that's where we are lacking. That's where we are coming from. So here, it's not the mistake of doctors or nurses or anybody. It's just a pure ignorance, and everybody has done that. I'm doing that. That's a culture. So how do we do as, I'm the medical director, I want to make sure the patient will come to us who sees a doctor, get all the right information. What we're doing at certain points during the patient journey is using a force function within our EMR. Okay, I'll tell you what a force function is. We, I think ours is the only group in the country which has developed its own EMR. We have our own software development company, so it's a homegrown EMR. So last year, this time, we had 0% compliance outpatient. Now we have 95%. The remaining 5% is because we can't get the visiting consultants to do it. That's the reason we have that non-compliance. So what are the force functions here? So our EMR is designed such a way that unless you complete some 6 or 7 mandatory fields when you see the patient, it's not going to print, it's not going to get published. Might sound very extreme, but it has worked. Okay, there are a lot of resistance initially, but it has worked. Number one. Number two.
But here, if I may interrupt here,
Yes.
this is a sort of a, when you are saying this force, this sort of cultural change, is it realistically possible to
You can come to
force it?
Narayana and I'll show you.
Okay, great.
So our AMRs, we have mandatory functions. Unless, for example, I'll just give an example. So when you open a patient's encounter, the first thing that pops up is, apart from the demographics, allergy. Unless you click the allergy and say what it is, you're not going to move to the next one. Unless you write the past medical history, it's not going to move. You can write not required, it's not available. Unless you write the medication in that format, it's not going to move. So a lot of issues initially, because they had to change the whole way of how the doctors look at it. But the way we did that is we engaged with doctors. This morning someone is saying it's not possible to implement it. It's not possible to implement it if you go top down and tell them do this. But if they are part of your working group, if you show
Okay.
them this is how it's done and it's important for patient safety, they will do it. So we have that. So thereby that communication is there now. It tells you exactly what the patient needs to know. Another thing is consent. We have digitized consents and we are also sending out soft copies with the patient. So again, another communication to the patient. So clearly tells you what the operation is about. And now it also tells you about the condition. Okay, that there's counseling before the operation, counseling after the operation, and patient leaflets. So these are all different ways you can.
So, if I may interrupt here again, some of these processes you mentioned, the first one or the digital consent, as far as healthcare regulations are involved, are they compliant or are there challenges in conforming?
We have gone through that iteration. We are okay with that.
Okay.
So we used to have, again, for every non-compliance that we encounter, we find a way of making it as a key performance indicator for the team or for the
Okay.
group. For example, consents was a huge issue for us. Okay, 3 years ago, only 40% of the patients had a proper consent. So doctor would have just signed it or something like that. So there are 6 aspects of it that needs to be done. We did one simple thing. We just told all the nurses sending.
There's accountability that is right.
Not send the patient unless the doctor did that. We have 100% compliance with OT now.
Excellent, excellent. That's really interesting and an eye-opener. Maybe from my media angle, I would say we would like to take it up as a case study from Narayana, the way that is implementation. Great. Dr. Mahendra, I'll come to you next. Okay. One example we just heard, and all these innovation, technology we are talking about, but Indian healthcare is a complex system, a population of this magnitude and so many. It's not just the private hospitals. There are private hospitals, there are government hospitals, there are these PHCs, tertiary healthcare, and first so many institutions, then the patients coming from different socioeconomic criteria, culture, and everything. So how challenging is it to make this operationally standardized across all these different kinds of hospital facilities that are available there? So what do you expect in a top-notch private institution, in a government hospital, in a smaller town, or a primary healthcare center in a remote area? It's not feasible. So how much of that standardization is practically can be done?
Right away, it starts with the medical education itself. The kind of communication, the kind of education what we impart at various sectors of healthcare, like the doctors, nurses, the technical staff everywhere. There is no standardized education module in the entire country itself. And the way of recruitment again, the way we ask them to perform, there is no standardization. So unless we have, like NHS in UK, which has a standardized protocol for every aspect of anything and everything. The British are very good in documentation and I appreciate the way they actually work.
NHS perhaps is globally one of the best, even
Yes.
within developed countries
Yes.
as a
So,
system.
unless in a country like us with nearly 1.4 billion population whose access to healthcare is still not that great, standardization of any procedures or standardized protocols for anything and everything across the country, whether it is private institution or a public institution, everywhere it gets easier to do. And availability of resources, whether you are in a metropolitan city like Bangalore or Mumbai, or you go to a tier 2 city, tier 3 town, if the availability of resources is the same, irrespective of the kind of place what we are going to see, the distribution of healthcare will be much easier. Because right now people from tier 2, tier 3 cities are coming all the way to urban centers and getting clogged, because of which the urban centers are getting much more busier. If these people would have been availing their services right at their doorsteps, wherever they are, with the same kind of quality healthcare what we can provide in a metropolitan city, I think that we would have achieved a lot of things then.
Exactly. Great. Thanks. Dr. Deepak, extending Dr. Mahendra's answer, what we are sort of looking at is a democratization of healthcare, if I may say. But what, in terms of how we had talked a lot, especially during COVID, it acted as a catalyst, was this remote telehealth, telemonitoring of health, and this remote patient care, which has again sort of come back to the pre-COVID days. If I say once the normal thing, no one is opting. But in the long run, do you see this remote health monitoring as a means which can, to an extent, democratize the healthcare process? Because thinking it will be fully democratized is perhaps utopian now thinking, but to a practicable level, some sort of democratization can remote healthcare do?
Thanks, Rajneesh. My personal viewpoint in this is that these things are just too diverse and complex to be standardized beyond a point. There are some basics, yes, standardization. Beyond that point, it is impossible to compare, let us say, a complex malignancy with a diabetic complication or a cardiac condition. It may not be possible. There are just too many conditions. If you say ICD-10, SNOMED, they have that many thousands and thousands of conditions. So what we can at best standardize is the basics. But yes, there is something. We focus on that 20% which gives you the 80% results kind of a thing. Let us say that large fraction of our patients are diabetics. That large fraction of these diabetics are dependent on insulin and fluctuations in blood pressure, prone for hypoglycemia. And so you introduce this continuous glucose monitoring, that kind of a chip you wear on your shoulder. And so then the patient is aware of it. So there is some that way role of a technology as such. So, but again, see, these are all limited to very specific conditions. But yes, there is great scope that way to focus on that 20%, which will give you 20% or 80% of the output. And that 20% we should not compromise it. And that's what Dr. Uthappa must have been referring to. That 20% which is key has to be entered. And it's not that you just enter one full stop something and move the next field. It will force him to enter that. So there again, the importance of a structured kind of an assessment, a structured kind of a way. These are the basics, sine qua non, not negotiable, absolutely essential thing that should be assessed, that should be monitored, that should be part of the care, and that should be part of the monitoring for the effects of your care. And also to see, yes, is he improving, worsening? Is there any warning red flags? And so I see this list itself includes 6 components. So it gets more and more complex. So then we have to choose which is the one where it makes sense to actually focus on no compromise and then do it. Again, how we integrate all this to get a one size fits most, if not all, is the big challenge which we are grappling with. We are moving in the right direction, but there's always scope to accelerate.
Okay, and that's true that this can be applicable only for some chronic cases which are non-immediate life-threatening maybe. Obviously for emergency situation, you cannot just depend, it will work as per the process, especially when healthcare being a sector when life is concerned. You can't have 99.99% compliance.
Here I'd like to point out the kind of impact we have had of what we call evidence-based medicine and protocolization based on guidelines. We have a number of bodies, and that's the whole thing. We have that many number of bodies, and each body will come up with guidelines for their key conditions. And again, you will find that the American guidelines don't quite match with the European ones.
True.
And our own Association of Physicians of India will come up with yet another Indianized guideline. But so that's the way we go in terms of what we call evidence-based medicine, guidelines, protocolization. To a good extent, but if you look at, I'm a 20th century doctor, I should say. So over my career itself, I've seen what we were taught, what I learned after I came out of college, and what I see today. There's a drastic change. So that the time frame is like this. It takes decades. But yes, things are moving faster and faster and faster, is what we would say. If you see how technology has advanced, otherwise, phone call means you have to dial. Today, I don't know what people think when I say dial the number means what really. So then we came with pagers, we came with mobiles. Now we have integrated devices doing everything we can ever think of. So yes, we are progressing.
Yes, great. Thanks. Dr. D'Souza, I'll come to you next. Now, another important aspect of this. Lot of these innovations we are talking about and a lot of things are also happening. But all of these things come at a cost. And that's ultimately passed on to the patients themselves. So from an hospital operations or a hospital management perspective, how do you take care of this budgetary challenges so that, because end of the day, if all the cost comes to the patient, then we come back to square one. Nothing good will happen. So how can an hospital take care of that?
So I think there are many stakeholders involved. It's not only the hospitals. So we also have big pharma. We have our equipment manufacturers. We have our consumer manufacturers. So we really need to bring all these people into the discussions if we are going to do lower costs for the patient. And I don't know if lowering cost is going to be the only way to go forward. See, because at the end of the day, we are trying to drive quality, and quality is not cheap. Quality comes at a price. We need to put so many things. Also, we are living in a litigious society. So people are ready to file in a lawsuit at the drop of a hat. So we need to be careful. We need to be supported with everything that is required to ensure that we don't go wrong in what we're doing. So I really don't know if I would say it's a balance. So it's a balance of best practices. It's a balance of good management, good cost management, good clinician management, good follow of protocols, because you can't undercut. And also dealing with all your vendors, suppliers, your other stakeholders in the whole aspect. And patients also don't want cheap care. Patients want the best. And that's what we've seen in Sakra. Patients want the best. They will ask you for more. So if that is the case, we need to be able to provide them more. That is the demand of the patient. Yes, of course, there is a large section of the society, possibly where we don't cater for that large section of the society, but a large section of the society which may not want such high standard of care, but you need to follow some minimum standard, because God knows it may come to bite you tomorrow in the form of a legal suit.
Okay. So maybe still in India, it's not to the extent of what happens in US or some other developed economies in terms of the legal suits, because legal care here is also expensive. So even,
What happened? All the interconnectedness with the ABBA. Patients have access
True.
to information all the time. See, in UK you have something called no win, no fee basis lawyers.
yes,
I was just saying, so with the ABBA, with all the interconnectedness, the patients will have access to the information 24/7, any time of the day, any time of the play, any time of the year, anywhere in the country. Okay, that will lead to so many other things. I'm not saying that's bad or anything. I'll just give an example. In UK, there are lawyers called no win, no fee basis lawyers. What they will do is, they will, the moment they sniff that something is wrong, first thing they'll come and do is give you an iPad. You keep the iPad, we will take your case. Now they have information. Okay, if I don't win, that's fine. You keep the iPad. If you win, I'll get such percentage of the litigation.
Okay.
So,
that's really interesting. Okay, next, I'll come to you, Srijit. In your earlier answer, you mentioned about sustainability also. And we heard just now Dr. D'Souza talking about balancing between the cost and the management. So my question is, when sustainability is also becoming big for hospitals, so along with this cost effectiveness of the budget as well as operational efficiency of the hospital, how do you balance the sustainability part also?
I think somewhere I feel that, sustainability increasing cost, I feel is a misnomer to start with. Because what I would believe is that if I take sustainability and break it down, right, there is of course environment, then there is social, and there is governance, all the three parts, components that we talk about, right? So what happens that naturally initially there is a little bit of a cost for the change that you need to bring in, the ways of working and things like that. But progressively it will actually help you to have much better operating cost. That's what I firmly believe, because I am seen this in multiple organization industries in the past also. So now, for example, right, I mean, one is of course the infrastructure cost, you'll say that I'll reduce the electricity cost, etc. That's one part of it. But there are also other parts like customer centricity as a theme, right? That's one of the themes that will come in. And then about employee empowerment as a theme, right? You need to have much more empowered employees. But eventually, what does this lead to? This leads to much better customer stickiness and much better outcomes and all these kind of things, right, that will come into. So I'll give you a simple example, right? I mean, we did a, Doctor talked about, waiting time for the doctors. We did a time and motion study of what exactly happens in a consultation. If you spend an hour or half an hour and see what the doctor does, right? And 70-80% of the consultations, at times we feel that doctor is seeking information, and many a time the information is not there, so the doctor will say, okay, go back and do a test and come back. For me, that's a wasted opportunity. So if I kind of flip it and say that I'll put a questionnaire up front, start collecting the facts up front, and of course things like ABBA and ABDM, obviously I'll be able to pull in some of the data. Then a lot of these kind of efficiencies will naturally come down.
Okay.
And next part of employee empowerment, right? I mean, I have to spend more on employees, but then we don't have 100% attrition. We'll become a preferred employer if I say that, okay, next time onwards I'll give a growth path, especially for our workforce, etc. And we've seen tremendous outcomes. My caregiving workforce, we have an employee upskilling program for that matter. They become center managers, they become multiple these things. So we've seen a lot of stickiness when we actually show them all these paths as per this SDG goals, and if I split it out across the various levers. That's the way I would look at it.
Okay, thanks. Thanks. Shrivalli, extending on what Srijit mentioned about what sort of trends you see in workforce management in a hospital, and what sort of enhancement in efficiency you see as a result?
Firstly, one most important thing before I could answer that question is, do we compare ourselves to developed countries? No, we can't. When we say a UK or a US and when we say India, we are way, way, way out of the league at this point in time still, yet I would say. But yes, I agree that there should be a method to the madness that we do and the work that we do. And I really appreciate the EMR, which does not allow us to move on further unless and until we are done with the allergies, right? So those kind of things, not only from a doctor perspective, but from each one of us in terms of workforce, if that is, laid, set as and when you start off your day one while you're working, from the lowest of the category of the interns to the top bottom, or from bottom top, whatever it is, we all have to follow the same language. Once we start following that, then the patient care automatically gets better.
Okay.
It's just not upon the doctor, or it's just not upon the operational. Now, coming to what you were actually saying, and what the co-panelists were also pointing out upon, is one thing that we all at this junction understand, that we have evolved from what we were 30 years ago, what we are now, or maybe in the coming decade or so. Robotics is giving so much of support. Then you have exoskeletons which are giving nurses so much of strength, wherein if I have to uplift a spinal cord injured person, I alone may not be able to do it, but that through technology we would be able to do. AI coming into picture with workforce again, both hand in glove, I would say, in the upcoming decade. But does that restrict all of us to do what we are doing at this point in time?
True.
No, we should.
Exactly. Thanks. So we'll have one last round with all the panelists, starting from Dr. Uthappa, and 1 minute to each of you. In terms of innovation in hospital operations, over the next 12 to 18 months, what do you foresee? It can be in your hospital, or it can be an overall trend.
Yeah, thank you for that. So I am very keenly involved with the EMR implementation in the group, quite passionate about it, and also involved in the development of the EMR, because development of the widgets and everything. So we have completed one phase of EMR implementation in outpatients. My next challenge is in implementing it in the inpatient services.
Okay.
We have around 20 large hospitals and 25 managed care clinics, so it's a major undertaking. So that will complete the entire process. Then there is, we have already integrated the RIS and LAS, and we do around 5,000 different audits in the group. Okay, whether it's financial or related to supply chain or related to facilities, and mostly it's from my department, clinical. We have automated the whole thing, but it's still not linked. So I would like to see that. The other pain point for us is radiology for the time being. We are very, very busy. We do around 7,000 chest X-rays a month. And if you had to imagine, that has to be reported by your doctors. But they still have to report ultrasound, CT scans and everything. So we are in the final phase of testing AI, software which is piggybacked by AI, which can give a report by the time the patient puts on the button and comes out. It's 99% accurate, and all it needs is doctor's validation. So looking forward for that to kick in, and the EMR adoption. Thank
Yes, that's the next phase. Yes, sir.
I too, I think, support what Dr. Uthappa says that today, the health informatics as such, in terms of a robust HMS available in a hospital or in a group of hospitals or at the national level, at different levels, wherever, access to healthcare by everyone, by all the stakeholders, whether it is the hospital management or the staff of the hospital, doctors, patients. Everybody should have an access to a robust healthcare information system where finally the devil lies in the data. And it is a data driven, and this is how we can always progress. So for me, I feel that a robust health information system in a hospital is of utmost importance, where you go paperless and introduce EMRs. Like many hospitals are still struggling to implement, though HIS is there, EMR is yet to establish because there is large redundancy from the consultants itself for not adopting it. They feel that writing is better than dictating or even typing. Okay, so there's much of resistance from the consultant sides yet. But if you make it compulsory that going ahead, this would be the way, people will adopt. But right now, we are all still giving them a choice that yes, if you don't do it, you can still write. And the second thing is available of AI. AI will definitely bring down the workload, work pressure on our consultants, definitely giving a quick diagnosis, except that they would only have to validate whether it is correct or not. That will save a lot of time for us. Healthcare informatics is another one where large scale data is available to know exactly what you need to concentrate on, what kind of health policies can be drawn by the hospital or by the country can always be coming.
Okay, thanks. Dr. Balani.
I'd like to take this opportunity to infringe a little bit and raise two aspects, and one is a subset of the other. The very first one is something that is actually kicked off, is already happening, and we are part of it, but it's moving faster, stronger and stronger. It is nothing other than this concept of accreditation. Under this guise of accreditation, typically NABH, somewhere JCI, we have actually undergone some degree of standardization. Some of the basics have been covered. What has technology got to do it? Perhaps not very, very much, but we are going there in the sense that, let us say, today all our NABH assessors, they enter it online real time. They have to take a photo directly from their camera with that geolocation tag, and then they will believe it. Otherwise, the body is not going to accept it. We need to track certain KPIs. We are expected to submit these KPIs every quarter. They are tracked by the APEX accrediting body, and so on and so forth. That is one aspect. It has laid down certain basic minimum standards. It's not that whatever a Sparsh or a Apollo does, that a smaller hospital has to do. No, there are separate standards for that many bedded hospitals. There are separate standards for entry-level hospitals. There are separate standards for Ayurveda, and separate standards for Ayush, etc. So they have tried to tailor the standards and tried to bring some degree of standardization. Of course, it's not very, very much to do with technology, but my gut feel you will see it kicking in. The second concept, very important concept, taking root very strongly, is a concept of patient safety. Here there is greater scope for technology. For instance, if you know what are our patient safety goals, the medical people know it all. The number one safety goal is not to, do that surgery perfectly or to treat that way. It is to actually identify the patient correctly. Did we identify the same correct patient and give him that correct medication, or did we give the wrong medication? Did we take information from a different patient than was it the same same Mahendra? Two Mahendras were standing outside my room, or did we see the same patient's X-ray? Did we talk to the same patient's attendant or relative who identify? That is the number one goal. As simple as that. How does technology play a part? Yes, again, EMR. There is medication safety, something. Something at the back end, even if it not be a, CPOE kind of a system where the medication entered online. At the pharmacy level, seeing what medications are indented. There are software which will simply give a pop-up saying these two drugs interact. Are you sure you want to give it? This is for hypokalemia. This is for hyperkalemia. Are you sure you want to give this?
Okay.
So there are things like, so integration at the back end also is a technology. Safety is what I'm getting at. In the OT, for instance, if the safe surgery checklist not entered, that machine will not function. So it's a mandatory thing for you to have entered the basics, so for you to proceed with the surgery. So safety is the other thing. Of course, it has limited concepts. It is not widespread that you can apply it everywhere and paint everything with the same brush. Not possible, but we are getting there. Safety.
Okay. Thanks. Dr. D'Souza.
So I think in my vision of what I'm seeing is one is definitely going to be AI. And we are also doing some work with AI in radiology, in pathology, and also in cardiology, some areas, especially for monitoring patients at home. So AI is definitely going to be one, and the other one is definitely going to be remote monitoring. So remote monitoring also has a big role to play, both for patients in the hospital also and outside the hospital. So I think these two standalone or integrated together is going to change a lot of things, a lot of dynamics within the hospital, how we do things, possibly improve a lot on efficiencies, what we were talking, the big subject, efficiencies, and also in terms of patient satisfaction, also reaching out to a larger volume of patients. So I guess these are the two things which I am looking at.
Thanks. Srijit.
Hi. So one major change I believe is that with all this technology, ABDM, etc. coming, this chief technology officer or information officer is going to be an inevitable thing for all hospitals.
Okay.
Right? Because it's getting too complex, the systems, their interoperability, how do I take data from A to B and how do I push it to ABDM? And now, for example, a lot of us are thriving on insurance approved care. Now we're talking about an insurance exchange that is coming. So it's going to be an inevitability that if you don't adhere to this, you will run out of steam sooner or later, right? I mean, and so this is going to be a major piece or theme for all of us, and directly or indirectly we are talking about it, saying that no, I'm bringing EHR, this thing, that thing, but that is going to be a major piece where we are talking about technology-driven care for each of us, charting our own path. Some of us may come with apps, this, that, extra. That is going to be one major change that I feel. The second piece is that along with that, you know, while we said that there is a kind of a dissonance, or there kind of some hesitation for people to use technology because typing is difficult, etc., especially HR context. But now the world is going so fast. Now we're talking about voice to text, image to text, this to text, that to text. So it's going to be a very, very different game where the data capture is going to be very innovative, and all these kind of new technologies come and bolt on. So that's going to be another increased cost of data capture which will come. Because if I had to do AI or anything, I have to first get the data in, right? So that's going to be another major piece that I feel will be a major thing. And last but not the least, with ABDM coming, I won't be surprised. I know it's too early, not ABDM, sorry, Ayushman Bharat coming. There could be more innovative healthcare delivery models, especially focusing on rural, right? I mean, I can already see in places like Orissa, there are companies that are picking up these models. And what we are talking about is something Vatsalya Care tried to do 20 years back, right? Trying to do a secondary driven thing in tier 2, tier 3C. That might become a lot more relevant. What about a low ARPOB model? You know, where I'm just kind of managing the primary, secondary, and kind of triage and push out tertiary, quaternary to a main center. Something like that. These kind of innovative models are waiting to disrupt. So we may see an Air Deccan coming out of the whole Jet Airways and Saharas or whatever when it was there, right? That's one more thing which is going to.
That's another interesting. So we have heard two aviation analogies today. Okay, Shrivalli.
Yeah, so coming 12 months to 18 months, definitely AI will be a tool which is going to support the healthcare professionals largely. It will also rather ease out the burden for a clinician, I would say, rather. And now there are people, or rather people who are passing out, this generation know it all, right? There need not be any teaching there that we have to do. It's just adaptation. But then the other set of group of people who still are old school but are willing to go ahead, which should be made compulsory. AI is the tool which I would definitely look forward for. And EMR, EMR is one that I strongly believe and vouch that would become and will bring in a lot of difference for us, the way we visualize all the parameters for the patient. Patient care is something that will be mapped through the EMR very, very well. And standardization of care, yes, through NABH and JCI, I do agree that there has been enormous standard protocols which are there, but that will not stop us to keep doing better and better with all the audits that we have. AI is one that I look forward for, and again EMR also, which will help all of us.
Okay, thank you. And so it seems that a lot of the future will be based around AI. With that, we conclude this panel discussion. And before we disperse, I would request Shangamitra Mohanty to come on stage and hand over the Excellence in Healthcare Award to all our panelists. Dr. P.M. Uthappa. Dr. Mahendra Kumar. Dr. Deepak Balani. Dr. Sandeep D'Souza. Srijit Narayana. Srivalli